Dr. Deshpande. Good afternoon, everyone. Our first speaker today is Dr. Delgado. She is an assistant professor of medicine, AHA hypertension specialist, founding director of the AHA Certified University of Miami Comprehensive Hypertension Center. Dr. Delgado is board certified internal medicine, former hypertension fellow, and faculty at the Division of Cardiovascular Medicine of the University of Michigan. Dr. Delgado was the recipient of the AHA Samuel A. Levine Young Clinical Investigator Award, the AHA Woman in Cardiology Award, the American Society of Hypertension Recognition Award for Young Investigator, the National Institute Health Biomarkers and Surrogate Endpoints Award, among others. Dr. Delgado has several publications, book chapters, and peer-reviewed publications in the field of hypertension and cardiovascular disease, with extensive experience in clinical, epidemiological, and bench research in the field of hypertension. Please welcome Dr. Delgado.
Hi, everybody. So today, I'm very happy to talk about hypertension, which everybody knows a little bit or a lot about it, right? It's everywhere. So what came out right now recently was the new guidelines from the American College of Cardiology. So will be an update from the 2017 hypertension guidelines. You guys probably know, but the publication is freely available. It's about over 100 pages, the new guidelines, and it's worth at least browse them, okay? They're very important information for everybody at any level of medical practice. The reason giving is that we are about to, no matter our specialty, but especially in medicine, at least 50% of our patients will be hypertensive. So just a quick reminder, the prevalence. So it's about 50% of our adult population. So the math will be, and this is the statistics from 2017 to 2020. And you can see the race, our African Americans are the ones that have more prevalence, but it's, if you put in an average, they are about half, both men and women. And when you see the 43.9% in women, this is also reflecting of the age. So at a given age, when you compare men and women, especially if they're in their reproductive ages, they will be somehow protected, even though they have a very well genetic risk for hypertension. So as women advance into perimenopause and menopause, then blood pressure dysregulation will be more pronounced. And here, again, this is from 2017 to 2020, but it's actually very similar to the prior statistics of rate of awareness, treatment, and control of hypertension between ages 18 and 80. And this is important because please keep in mind, hypertension is not an old people disease. It's actually a disease of humanity. So you can have children with very early onset of hypertension, as well as I mentioned, women starting at perimenopause age and people starting as a young adult or after 50 or 60. It doesn't matter. It's just we need to be aware that there is hypertension at a very, very wide age range, and we need to be careful not only in diagnosis, but in advising these patients how to treat hypertension. So what is new? I'm going to try to just, as fast as I can in terms of time, I just want to give a comparison of what happened in 2017 and what happened now in 2025. So one of the things was the terminology of hypertensive urgency. So now we call it severe hypertension. So this is to avoid the emotional response that we have to hypertension urgency. And just to understand that when a patient has high blood pressure and is asymptomatic, it's considered severe hypertension. It means that most likely the patient did not took his medication, is not being treated properly, and you can literally follow the patient, start or reinitiate blood pressure treatment, and you don't have to send the patient to the ER. So basically, this is the separate severe hypertension from what we used to do with hypertensive urgency, that there was always a confusion of, do we treat this patient urgently, or do we wait until they see their primary, or do we initiate any treatment? In primary aldosteronism. So nowadays, and for the last, I will say a little bit over 5 years, there's a growing interest in understanding aldosterone in hypertension. So not only primary aldosteronists, but also patients with increased sensitivity to aldosterone. And in these cases, aldosterone level will be elevated, but not to the point of being primary aldosteronism. So the advice is that 2025 have is that when you have a patient that you suspect primary aldosteronism or aldosterone sensitivity, is to continue their antihypertensive medication, okay? And if the patient is on a spironolactone or a eplerenone, you can withhold it until you do the workup, and then most likely, if you need to, you will reinitiate it. This is actually very interesting. Most of us that we know hypertension forever, the most important non-pharmacological intervention is low sodium diet. Eat low sodium. And that makes sense from the physiological and also from genetic standpoint. And about 70% of the hypertensive global population will have some degree of salt sensitivity. So it makes sense. But however, we slowly start understanding that potassium also plays a very extraordinary role. And there were patients that naturally have low potassium, especially in the intracellular compartment. And this, if can be added to the fact that many of them have aldosterone sensitivity. But now, for the first time, it actually is a recommendation, whether you are with or without hypertension, to try to use potassium-based salt to prevent or treat elevated blood pressure. But just keep in mind that it's not only not using the sodium, but also increasing, right, potassium content, with all the how careful we need to be with chronic kidney disease. If you guys never tried it, try what is a potassium-based salt, and you will notice the difference. It is a salt, but it tastes very bitter. So that's probably one of the problems that we have with patient compliance in terms of potassium-based salt. But as you go and as the patient gets used to using it, then it doesn't bother them. So when do we start? What is the initiation threshold compared 2017 to 2025? So in 2017, you start the medications when the blood pressure is over 130/80. When is for clinical cardiovascular disease, when the patient has clinical cardiovascular disease, or when the ACCBD 10-year risk was over 10%. Now, what we did is actually bring the risk cut point down to 7.5. And basically, you're going to start medications in adults without clinical cardiovascular disease who have either diabetes, chronic kidney disease, or the prevent 10-year cardiovascular disease risk is greater or equal to 7.5. And all this to reduce cardiovascular disease events and total mortality. And this is important because we tend to, unfortunately, when you see historically a patient in clinic, you will see that probably a good 10 to 15 years will go by with uncontrolled hypertension. And that gives enough time for the vascular system to translate into target organ damage. So early awareness of who is your patient. Is it a simple hypertensive patient, no other comorbidity, no other risk, versus somebody who comes already with risk? That's one of the most important interventions or recommendations of the new guidelines. Again, for primary prevention or low risk threshold, in 2017, start medication for adults without cardiovascular disease when the ACCBD 10-year risk is less than 10% and BP greater than 140/90. That had changed. Now we're telling a patient, okay, now you have a young person or not so young that they only have discrete elevation of blood pressure their prevent risk is less than 7.5%. What do you do initially? So the recommendation is to do lifestyle first. Change the diet, exercise, stress, sleep management. But you're not going to wait 10 years to decide what you're going to do in terms of pharmacological intervention. So literally, the time frame is about 3 to 6 months. So these are patients that you see initially, and then you're going to see them again in 3 or 6 months to see how they respond to non-pharmacological intervention. And if the blood pressure remains over 130 over 80, then you can start giving blood pressure medication. So this is very important, especially in young people, 80 and over, that we tend to let them go with their abnormal blood pressure response for decades. And this is just a table. I strongly recommend you to go to the American Heart website. The prevent cardiovascular risk is actually something, it's an application within the American Heart website where you can put your patient's data and it will give you actually the risk. Diabetes plus hypertension. So in 2017, ACE-ARB may be considered when albuminuria is present. Now in 2025, we went from may consider to an actual recommendation. And they explicitly define the chronic kidney disease criteria based on GFR, as well as urinary albumin creatinine ratio, okay? And to consider even in presence of mild albuminuria, meaning less than 30, to slow diabetic kidney disease. Now, in chronic kidney disease plus hypertension, we have in 2017, again, ACE inhibitor reasonable for chronic kidney disease stage 3 or greater, or stage 1 or 2 with albuminuria greater than 300, and RB may be reasonable if ACE inhibitors are not tolerated. Again, we went from reasonable to recommended strength, and the albuminuria threshold changed from 300 to 30 milligrams per gram. And the definition of the GFR is also very explicit. In that case, less than 60 ml per minute, 1.73 meters square, with the albumin creatinine ratio greater than 30. So basically what we're telling you is don't wait until there is significant renal damage. You can start pretty early in the prevention of progression of chronic kidney disease. In terms of intracranial hemorrhage and blood pressure target, there was no mention in 2017, but in 2025, with adult with acute intracranial hemorrhage and systolic blood pressure greater than 150 over and 220, the recommendation is to lower to 130 and less than 140 and maintain this level at least for 7 days to improve functional outcome, but hold it if the systolic blood pressure is less than 130. So basically the 7-day maintenance and to stop medication if it's less than 130. In 2017, again with intracranial hemorrhage, if systolic blood pressure was greater than 200, it was reasonable to use continuous IV antihypertensive with close blood pressure monitoring. So here, for patients requiring acute blood pressure lowering, careful titration to achieve a smooth, non-labile sustained control, avoiding systolic blood pressure peaks and large variability. So basically, this is one of the most important things that we encounter in the hospital setting and in the units. How aggressive we go, and when it's intermittent, especially intermittent IV treatment, you're going to have labile blood pressure, and that presence of labile blood pressure or sudden peaks and down is actually worth for the outcome. So the recommendation is slow titration and avoid variability or severe variability. So there's a harm statement as well. So from 2017 to 2025, the harm signal shifts from early intracranial hemorrhage over lowering to over lowering after reperfusion in ischemic stroke. So especially being very careful in terms of the specific blood pressure targets. So after successful brain reperfusion, reducing systolic blood pressure to less than 140 within the first 24 to 72 hours can worsen long-term functional outcome. So very careful in lowering the blood pressure post endovascular reperfusion. So cognition, and this is very important because we all know this. And when we try to recommend, patients are very confused. They believe many things, but they don't understand that blood pressure actually is a extraordinary risk factor for dementia. And in 2017, it was reasonable as a recommendation to lower blood pressure for prevention. But in 2025, basically it's recommended to keep the systolic blood pressure less than 130 to prevent mild cognitive impairment and dementia. Pregnancy is another new one for the 2025. If systolic blood pressure is greater than 160 or diastolic greater than 110, you need to confirm within 15 minutes and treat promptly to reduce blood pressure to less than 160 and less than 110 within 30 to 60 minutes to prevent adverse effect not only for the mother, but for the baby. So you have to, and this is obviously OBGYN, but what we need to be very careful in terms of what is a severe hypertension in a pregnant woman compared to severe hypertension in a person not pregnant, which you don't need to lower the blood pressure immediately. Here, you need to actually act. Also for chronic hypertension in pregnancy, with systolic blood pressure between 140 and 159 or diastolic blood pressure between 90 and 109 before the 20 weeks of gestation is what defines chronic hypertension in pregnancy. And you need to initiate antihypertensive therapy to reach less than 140 over 90. And this is both to reduce maternal and perinatal morbidity. And there's what changed also is that there's explicit concealing recommendation on low dose aspirin in hypertensive patients pre-conception and during pregnancy. So if you have a person who wants to be pregnant, besides all the recommendations that we need to do in terms of what blood pressure medication we need to give her, once she decides to be pregnant, she needs to be started on low dose aspirin. And here it's said exactly the same thing. For individuals with hypertension who are planning pregnancy or already pregnant, we need to initiate the low dose aspirin. Okay, pregnancy, medications to avoid harm. In 2017, do not treat pregnant women with ACE inhibitors or direct renin inhibitors. In 2025, it's actually a little bit broader. Avoid atenolol, ACE inhibitors, ARB, direct inhibitors, renin inhibitors, nitroprusside, and mineralocorticoid receptor antagonists to prevent fetal harm. We kind of know this already, but it's now very well specified in the guidelines. Resistant hypertension and secondary evaluation, perform a detailed workup for secondary causes, including systemic medication review, and this is important, and removal substitution of blood pressure interfering drug. And remember, we here at the University of Miami, we have a lot of cancer patients, and many of the biologicals used for cancer will impact blood pressure regulation. In this case, we adapt and we understand that blood pressure regulation is being modified by the treatment, but we don't stop the treatment. But it's important to understand what is that the patient is taking that can be causing resistant hypertension. Here at the University of Miami, we have one of the first academic programs with renal artery denervation. So I'd invite all of you to inquire. This is now the third pillar of blood pressure treatment. So we have non-pharmacological, pharmacological, and renal artery denervation. The decision And the process is actually a team-based renal artery denervation program. So we have hypertension specialists, we have our fellow, we have the first fellowship in hypertension now in the Division of Cardiovascular Medicine, and we have interventional cardiology, plus all the staff surrounding the process of renal denervation. So this is an exciting new era in treating resistant hypertension, especially in patients with increased sympathetic tone. This is again, it's a procedure that involves a cath, and that's why I discussed that is a program. This is not come and get a renal denervation. We actually discussed the case. We analyze what patient could be a good responder or not for renal denervation, whether they classify anatomically. So this is actually a great opportunity that we have here at the University of Miami. Okay, this is very important for all you guys, especially hospitalists and doctors that are working in the hospital. And it's this need that we see when the patient blood pressure is 180 over 120, then they're in the hospital setting. The intention is to try to bring it down either with IV or oral antihypertensive in an acute way. The harm is to discourage acute intermittent blood pressure lowering in non-cardiac inpatient. Of course, you have a patient with heart failure and you have bad blood pressure, the patient will be in pulmonary edema. So we need to put it within the context. But the great majority who have no cardiac condition within the inpatient setting, we should avoid trying to acutely decrease blood pressure. Really quick top take-home messages. First, please keep in mind hypertension is the most common modifiable driver of cardiovascular disease, dementia, chronic kidney disease, and all-cause mortality. And for most adults, the aim is less than 130 over 80. Please put it in the context of who is your patient. An elderly patient with this isolated systolic hypertension is not the same as a middle-aged adult or a young adult. Hypertension is a social disease, so you on your own, you can't. You have to involve the community, the families. It's a family disease, so it's one member of the family have hypertension, you know by extent that the children and the next generation will be hypertensive. It is a team-based disease. We need not only the physicians, we need pharmacists, we need a nurse practitioner, nurses, dietitian. We need a group of a team that will help not only treat the hypertensive patient, but maintain blood pressure control throughout the patient and their families and their communities. This is just a little reminder of the blood pressure classification that hasn't changed from the last guidelines. And first of all, for any person that you're considered treating for hypertension, the non-pharmacological pillar is essential. Diet, weight, stop toxic habits like alcohol, smoking, drugs. And now we introduce the potassium salt. I get a reminder that add medication with lifestyle for all adults with average of 140 over 90 and at greater than 130 over 80. Remember, if you're totally absent of cardiovascular risk, you can do 3 to 6 months of non-pharmacological treatment. But if you already have signs of cardiovascular disease, stroke, diabetes, chronic kidney disease, or prevent 10-year risk of greater than 7.5, you need to start treatment. For prevent, that's what I mentioned just now, less than 7.5, you start lifestyle first. But if it doesn't work, you need to start treatment. And the whole reason about this is hypertension is not static. It's not a picture that you take and then you disappear. It evolves as you get older. So any young people that you see with no cardiovascular risk and blood pressure in the 130 over 80, they're going to get older. And eventually the blood pressure is going to get severe or harder to treat. There's a lot of, for stage 2 hypertension, you want to start with 2 first-line agents. It will depend also on patient's phenotype, biochemical behavior, but if it's possible and you can start on a single pill, that will be great. Not everybody can qualify for single pill, not because of the single pill, but because of their physiology. Important, and you all know that, is blood pressure monitoring at home, either self or with an ABPM. We routinely use here for the last 2 or 3 years, cuffless ABPM, but we also use the cuff ABPM, and this is done routinely on every single patient that comes to the hypertension clinic. But you can also, and you should teach your patients to actually learn how to measure their home blood pressure. And this is, again, the last one is severe hypertension in non-pregnant women. You need to treat. You cannot just let it go, like in severe hypertension in severe hypertension, non-pregnant woman, you let it managed by the clinic, you restart, intensify oral medication, but if it's pregnant, you need to treat. Just a little, 2 seconds left, just to say that this presentation is in memory of my father, who was my mentor, my research collaborator, since I know myself. And reviewing the guidelines, it brought me back the fact that this conversation about aldosterone, potassium, especially in the intracellular space, and uncontrolled hypertension, I had it when I was 18. With him, the research that I did with him was what allowed me to go to Michigan as a fellow. And then, well, here I am. So please go back to your family and understand that you bring not only the genetics, but you bring whatever they give to you. Okay? Well, thank you very much.
Thank you so much, Dr. Delgado. And you see all the hearts, our condolences to you. I'm sure your father had a tremendous impact, and this was a great overview. I think reaffirming a lot of what we've historically done, but really important updates over the past decade that really highlighted some things that we can do differently. And just a quick question, there might be others, and I'm happy to take any questions for about a minute or two before we move on to the second talk. But you know, you guys obviously have a specialized clinic at UM, but when you talk about home blood pressure monitoring, team-based approach, and things that are so important, any comments on any ability, how successful we've been able to do that in the Jackson system and other places that have reported underserved urban areas or rural areas, the ability to create good team-based approaches and accurate home monitoring?
Yeah, so I think we have an extraordinary resource that is available for everyone, which is the Target BP from the American Heart and the American Medical Association. So what we need is to teach them, to teach the patient how to take their blood pressure. If the institution or the clinic can actually provide the blood pressure cuff, right? That will be great, but we have the resources at any level. What I think is important is the continuity of care. So we see a hypertensive patient, you teach your patient how to take their blood pressure. They go home with a clear, you know, you're going to write your blood pressures here in this form. If there is no follow-up, that's where the break in care, you know, happens. Look at the guidelines. The guidelines, they're telling you, even in a person who is 18, who has 130/80 and no cardiovascular risk, you want to see this patient at 3 months. You want to see them at 6 months, you know, because it's progressive in time. But we do have, I think the Target Blood Pressure Program is extraordinary in all the recommendations of how to teach the patient. There is significant amount of information that we can give out to our patients in different languages. So we can print it out, give it to the patient. All the dietary recommendations are there too, in different languages. So that's one way of doing it. And again, and if I may, for just another 2 seconds, I remember I had a meeting with the American Heart, and we were talking about different, you know, cardiovascular centers, including hypertension centers, and all the things that we want the community to have. And then, like you said, we have underserved communities that don't have any privilege at all. So when I mentioned diet, exercise, sleep, work, happiness, peace, we don't have that for our patients, you know, for the underserved. We can't tell a patient who works 3 shifts or work the night shift or have $10 to buy, you know, the breakfast for a week for their children, to have a low sodium, no preservative diet. So it's a culture. That's why hypertension is not only culture, but it's a social problem. And we're going to have a completely separate road. There will people that at 80 will be perfect cardiovascular, good brain, and there will be people at 40 already with a biological age of an 80-year-old, very sick.
Thank you. Thank you so much. Short on time. I know there's some questions in the chat that maybe you can answer either offline or directly to those people. So thank you so much for that. So we'll move on to the next talk with Dr. Doblecki. Dr. Espinosa, are you introducing again? Okay, great.
Sure. Thank you, Dr. Susanne. So our next, the next one is Dr. Susanne Doblecki-Lewis, is a professor of clinical medicine and chief of the Division of Infectious Diseases at the University of Miami and infectious diseases clinician in the Jackson Memorial Hospital and the University of Miami. Her clinical and research focus is on improving access to HIV and infectious disease prevention strategies for underserved populations. She is the director of the RAPID program, which provides no-cost, low-barrier HIV and STI treatment and prevention services in a community-based mobile clinic that serves 5 Miami neighborhoods and a fixed clinic in the Converge building at the Medical Campus. Dr. Doblecki-Lewis has received numerous federal grants as PI and COI to evaluate strategies, including mobile clinic delivery, social network approaches, and long-acting injectable implementation support locally and in multi-site context. She also directs the Infectious Disease Prevention Clinical Research Unit, which engages in clinical trials related to long-acting treatment and prevention for HIV, Mpox, and other infectious diseases. Please welcome Dr. Susanne Doblecki-Lewis.
Great, thank you for that nice introduction. And I think I'm here probably largely because the organizers of Grand Rounds, just like probably most of you in the room, have been getting a lot of emails, texts, UChart messages about what to do with the COVID vaccine. And so I'm hoping I'll be able to provide a little bit of clarity. Here are my disclosures. So not mentioned once, I think, in the introduction was COVID, but, and I think all of us are trying to maybe forget or selectively forget that that era, which isn't quite over. But and I put this as a disclosure, I was the principal investigator here at for the NIH CoVPN phase 3 Moderna vaccine trial, part of Operation Warp Speed, which was led by President Trump in his first term and supported by Governor DeSantis. You can see in the picture here when Governor DeSantis and Mike Pence came and visited us at as we were launching the Moderna vaccine trial. Seems like a very long time ago. And given the more limited approval of vaccines this year, I will be discussing some off-label use. You can also see my other disclosures, which are not really relevant to the presentation today. So here's what I'll try to cover in the next 25 minutes or so. So we'll talk about an overview of disease and where we are now in 2025. Also, what we know about the benefits of vaccines and, the accumulated knowledge in the last 5 years about risks of vaccines in the context of lots of vaccination as well as of naturally occurring disease. And then we'll spend some time talking about the vaccine rollout this year and hopefully give some information that may help you to inform your patients. Okay. So let's go through the looking glass back to 2019 and 2020. So things felt very different in 2020. Many of you remember well the trauma of the initial surges of COVID and the devastating disease that we saw then. And the mRNA vaccines were introduced at that point to a generally COVID naive population. So the initial vaccine efficacy was 94, 95% of these mRNA vaccines for symptomatic COVID, so really any symptoms. And they also had excellent protection against severe COVID-19. So I think, you know, it's really important to think about context here. So there was a really strong match between the initial strain. It was very early on. We hadn't had evolution of these variants. And there was also a very little baseline antibody in the placebo group, right? So most of the people had absolutely no COVID antibody. So really saw a very big difference between the vaccinated folks and the placebo group. And now when you look at COVID and the deaths, you know, death rate over time, it's obvious, first of all, that there's been a really steady and dramatic decrease in the number of deaths that occurred. And that's really happened as immunity has expanded due to natural disease as well as due to vaccine. And you also can kind of see that there's some seasonality and some periodicity to this. And when you drill down a little bit and look at antibodies, this is from blood donor data. All right, and they shifted the assay a bit in 2022, so there's some noise there. But you can see, looking on the left, these are everybody who had antibodies to the spike S1 protein of SARS-CoV-2. And by the end of 2023, it's over 95% of people, US adults. On the right, you can see what portion of these antibodies were due to natural infection. And, you know, looking before 2021, it's mostly, you know, all of it, you know, comparing the left and the right is due to infection. This is before the vaccines were rolled out. When you look between 2021 and really most of 2022 as well, the antibodies were mostly from vaccination. And then now everybody's just got a lot of antibodies, right? So that's kind of where we are now from 2020 through 2024 and on. So then, you know, getting back to the periodicity, I think this is really interesting and something that we've seen, you know, with the lens of time, is that we do have these biannual spikes in the winter and in the late summer. Many of you experienced this within the last month or two. I mean, just a huge number of cases. And it's really been pretty consistent. We're in region 4, so that's the blue lines here. And, you know, kind of looks like we're at the top of the peaks most of the time, which feels like what we're experiencing too. But really, these are all going together. So, you know, regardless of when you're in the West Coast, the East Coast, the North, the South, we've got these strong peaks. And that's probably has to do with the strains that are circulating. It also has to do with social gatherings and patterns of connection and weather and stuff like that. But I think it's something that we now see really does alternate almost every 6 months. We'll come back to the 6 months pretty soon. And then variants, we all hear about variants all the time, and this is the CDC Nowcast, where they're tracking, you know, really carefully the proportion of variants that are circulating. And you can see this is just the last year and going up until like 2 weeks ago. And there's just always something new, right? So we're now in the XFG world, but before that, which is really a subvariant of many of these shifts are rather small of the LP8.1. But each time we see a large shift or a more major variant emerge, you know, it kind of predicts the disease that we see in the population. And so pretty much, you know, every 6 months, we're seeing these big shifts as well. Okay, so in this context, what are our considerations for vaccines? Well, first of all, I think we have to drill down and look a little bit about who is getting disease and who's being hospitalized with it. So very clearly, when you look at the rates of COVID-associated hospitalization by age group, it's people over 65 who are still very much affected in terms of hospitalization and then also in terms of deaths. So really, you know, let's focus on those populations that are most impacted. And here, especially when you look at 2024 and 2025, everybody else is really much, much lower in terms of rates. And then we can try to look at vaccine effectiveness. This is often done through these large network studies that use generally a test negative design. So one is the Vision Network, another is Ivy. The UHealth Towers is a site for the Ivy network. Dr. Mallow in pulmonary is the lead here for that. So they're looking at people who are hospitalized, what is their vaccine status, and how does that, when were they vaccinated as well? And what you can see is that this is 2023 to 2025. We're always just a little behind on data because these things change very quickly. And VE is highly impacted by circulating variants, by what is the prevalence in the community, and by how recently people had vaccine, how well it matched with the variants, et cetera. So, but when you look at this, you can see that within the first 60 days or so of vaccine, we're looking at a VE of maybe around 50%. And that's both for pretty much for all ages. Once you get out to a few months, and then certainly 6 months, that the vaccine effectiveness decreases dramatically for everyone. And I just wanted to quickly mention that this is the case for pregnant women as well. And pregnancy is a particularly vulnerable time for COVID infection. So it's the same 6-month kind of window here where you compare people who had the vaccine during pregnancy with a VE of about 50%. And then less than 6 months before pregnancy goes down by about half. And then more than 6 months before pregnancy, kind of non-existent. But beyond the vaccine efficacy, I think really important is to keep in mind in each population, what is the number that you would need to vaccinate in order to see a benefit? And this is where the data really diverges, depending on whether you're talking about high-risk groups and people 65 and older, or non-high-risk groups. So just to walk through this quickly, the number needed to vaccinate to avert a case, this is modeling data from the CDC, is not that different, right? So when we're talking about a case, just meaning a positive test or symptoms from COVID, is not that different across all of these groups. However, when you're looking at the number you would need to vaccinate to avert a hospitalization, it is quite dramatically different, right? So this is not how many people will need hospitalization or, a proportion. It's, layering on top of existing immunity from previous infections and then adding on to that and vaccines and adding on to that a new vaccine. How often would you expect to avert a hospitalization? All the way from something around 300 for people who are over 65 and high risk to, more almost 16,000 for younger people who are not high risk. And then to avert a death, the numbers are even more dramatic. So I don't take these as absolute numbers. There's a lot of potential artifact from modeling here, but I think relative numbers are really important. There's a huge difference in terms of what you're going to get, what we'd expect to get in terms of benefit from high risk versus low risk and older versus younger people. So what about other benefits from vaccine? So one thing that's come up, and I don't want to oversell it because I think it's really difficult to get good data on these, but looking at how does vaccination impact transmission to other people, right? So many people will consider getting vaccinated, not for themselves necessarily, but because they are caring for someone who would be considered high risk or who's older. And there are some data. This is data that was presented at the CDC ACIP meeting, and it's preliminary, but this is looking at the reduction in transmission to household contacts that occurs after vaccination. And again, it's a 6-month number. So for vaccination within the last 6 months, you do see some benefit, potentially about 45% decrease in transmission to household contacts. That benefit starts to not look significant at more than 6 months. So relatively time limited and sort of mild to moderate benefit in potential in lowering transmission to household contacts, but something to consider for sure. So another question or another concern is whether vaccination could be associated with decreasing the risk of long COVID. And I think, everybody or many people are concerned about long COVID. This again is difficult to get data on, both because the definitions of long COVID can be all over the place, and it's also changing quickly. So these data are from 2021, 2022. We don't know how well they apply to the current era and what we're seeing now. But in these studies, and Dr. Lisa Gwynn from pediatrics was involved in the study that's described in children here, and there's another study similar in adults, did show a reduction in many of the symptoms related to long COVID among people who had received full vaccination of the original series or 3 doses. Okay, so potential benefits, but let's talk about safety. Safety is in the news a lot. So we have a lot of different monitoring systems for COVID vaccine or any vaccine safety. VAERS is one that you may have heard of. It is the kitchen sink of vaccine reporting. So anybody can report to VAERS, including providers, manufacturers, and patients themselves. So it is taken very seriously just for trends, or, folks look at these data. If there's something that's emerging as a trend, it is further investigated. It's not to be taken as gospel until further investigation has happened, but it is a way that some uncommon side effects have been identified after release of vaccines. There are a bunch of other vaccine monitoring systems in place as well. Some are more active and some are more passive. Some are linked to electronic health records or Medicare claims databases, and just trying to look for modeling for any kind of emerging trends. So for COVID-19 vaccines specifically, I just wanted to go through some of the safety signals that have been investigated to date. So myocarditis and pericarditis, I have another slide on this because I think it is one that comes up quite commonly. So we'll talk about that on the next slide. Anaphylaxis is not common. It's rare. As with any vaccine, it is a possibility. Does not seem to be a particular risk with these vaccines. Thrombosis with thrombocytopenia or TTS. So this was seen and was considered associated with the Janssen vaccine only, a vaccine that's no longer used. It was identified. I think it's a good demonstration of how the safety systems can work to identify rare associations with the vaccines. This was about 4 in a million, but it was one of the reasons why that vaccine was not further pursued. Guillain-Barré syndrome did have a slightly increased risk with the Janssen vaccine, but not with the mRNA vaccines. So that has not been seen as a risk. Bell's palsy was initially there was potential that there was some signal there, but it's been further investigated and found to not be associated any excess beyond background. Syncope is a common event across all vaccines and not associated more so with COVID vaccines. And importantly, we have quite a lot of pregnancy data now. So from pregnancy registries, we have more than 300,000 pregnancies that have been monitored with no increased risk and no new delayed onset events through 2025. Oops. So back just briefly to myocarditis and pericarditis, because I think this one comes up a lot. So what we know is it is more common in males and in those less than 40 years old. The risk really decreases a lot after 25 years old. So really between 12 and 25 is where it's been seen. It's more common after the second dose in the primary series and much less so in the booster when those have been received, or seems to be. Most of the time, this vaccine-associated myocarditis, when it happens, is not severe. So 90 to 95% fully recover, median hospital stay of 1 to 2 days, and there's no long-term mortality signal. And we also know a few things, like increasing the interval between the first 2 vaccines to more than 8 weeks can decrease the risk. And I think also importantly, and this is with the figure at the top, you can kind of see the risk with COVID-19 infection itself is not insignificant for myocarditis relative to this. So the left panel here is showing among all comers all adults, myocarditis risk, and this is per million, excess events per million people. So for people having an infection, we're talking about around 40 per million. And then the mRNA, these are the Moderna vaccines in orange. There is a risk, but less so. And then with the Pfizer, and then this was the adenovirus-based vaccine, there was really no particular risk. When you drill down to look at males under 40, you can see that there is a risk that is slightly exceeds that of the virus infection, the natural viral infection itself, among males under 40, and with the Moderna vaccine, second dose only. However, for pericarditis and other cardiac arrhythmias, it's really a much stronger signal for natural infection than for vaccine. Okay, so let's talk about what's been happening now. So what's available this year? So sort of the usual suspects. So we have Pfizer and Moderna. There's a little difference in the FDA approval, which we'll talk about in the next slide. There's also the Novavax vaccine, which is a protein subunit vaccine with a matrix M adjuvant, which is a good option for people who just don't want to get mRNA vaccines. There's also a new player, which I think is interesting. This is the Moderna M-Next spike vaccine. So what's different about this? Rather than having the full spike protein encoded in the mRNA, it only encodes the NTD and RPBD regions with a linker. This allows it to use a lower dose, and so it's only approved as a booster. So for previously vaccinated people over 65 or with comorbidities, it does seem it was shown to be non-inferior to the Moderna Spikevax, sort of more traditional mRNA vaccine, and actually had about a 14% increase in vaccine efficacy among people over 65, although the trial wasn't powered to look for superiority. So this is available as well and is a consideration. I know they have it at some of the pharmacies nearby. Oops. Okay. So quickly, I wanted to walk through the vaccine approval process. I know it feels like we're in the thick of this right now. The last step's just happening on Monday. But basically, just, you know, for familiarity, generally what happens, and if you look on the left last year, this is what happened, was generally what does happen, which is that the VRBPAC recommends what the vaccine should look like in terms of updates and what lineage to use. And then the manufacturers will present those vaccines. The FDA approved them last year for everyone over 6 months old, with some variation by vaccine, but that's the sort of the totality of it. The ACIP, which is the committee that advises the CDC, had recommended that this vaccine would be available and recommended for everyone over 6 months old. And then that CDC confirmed that recommendation and gave some further guidance around a second dose for people who are older and immunocompromised. So, and then vaccines were available. This year, same thing from VRBPAC, but the FDA narrowed their approval. This caused some consternation. Folks were not sure whether it would be available or it would have to be off-label for everyone else. The ACIP met. They actually did not recommend that the vaccine be limited, but did recommend shared clinical decision-making with an emphasis on people who had higher risk for severe disease. There was kind of an unusual about 2-week delay before the CDC director accepted those recommendations, but that did happen on Monday. And we still don't have sort of updates on the more general guidance and clinical considerations. Now, because of all of that kind of delay and a little bit of a different approach this year, there have been some additional bodies who have emerged with their own guidance. So some of the states came up with guidance. Also, some of the medical associations, our Infectious Disease Society of America is developing a guidance. Dr. Shweta Anjan from our division is part of that. There is no official Florida state guidance. If you look at the website, it still has the 2024 guidance. And there is a statement that the state Surgeon General advises against the use of mRNA COVID-19 vaccines, but there's no policy associated with this. The Florida Board of Pharmacy has confirmed that pharmacists can administer vaccines to people over 65 or with other conditions. And importantly, the health plan administrators have said that they will continue to cover all recommended immunizations that were recommended as of September 1st. So that was before that's kind of last year's recommendations, including updated formulations with no cost to patients. So what do we do? So I just want to point out that COVID vaccines are not overutilized. In fact, only 15% of adults in the Southeast received one last year. And we do have really significant gaps. So people over 65 is less than a third, pregnant women, less than 15%, people with immunocompromised, less than a quarter. So, and the percent of adults reporting that their healthcare provider had recommended a vaccine was, less than a quarter for COVID-19, and kind of surprising to me, it was significantly less than for flu. So my recommendation is keep talking. Your patients are listening and they have a lot of questions, right? And I thought this was interesting. This is from the Kaiser Family Foundation, very recent survey actually. And people across the board, regardless of their political affiliation, they do have a great deal or a fair amount of trust in you to provide reliable information about vaccines, way above everybody else, including the Public Health Department, the CDC, and RFK Jr. So you do have a lot of power. And please use it. Thank you.
Thank you so much for that that excellent talk, because we all get asked these questions all the time, and I was particularly found helpful that the kind of the opposite of the number needed to treat the for hospitalizations and deaths, and how I think the challenge with shared patient decision making is that many people historically haven't gotten this through their doctor, but just through universal vaccination, and that's obviously a lot harder to schedule an appointment and talk to a doctor, and especially when your doctor yourself may not have all the answers. So I think, I guess, like everything, there's maybe more questions than answers, but thank you for that very helpful overview. We have a couple in the chat. I'll start with the one that's live. Dr. Goldberg, you want to unmute and ask your question?
Yeah, so because I've heard a lot of information, maybe misinformation, do patients need a prescription if they're under 65? Because when I went to my CVS a couple of weeks ago, they said, oh, you need a prescription. So what is the actual logistics?
I have an answer to this. I'll do it quickly. So no, you do not need a prescription. I have confirmed. I called multiple CVS and Walgreens pharmacies in addition to looking at the information. 2 weeks ago, this was not the case. So 2 weeks ago, before the Florida Board of Pharmacy had said that pharmacists were able to give immunizations without prescription, they were briefly requiring this, and it caused a lot of confusion. Right now, you do need to state either that you're over 65 or that you have a medical condition. It doesn't have to be very specific. So it's more just like self-certification that there's if you're under 65, that there's a medical condition. It's can be done on the website when you're booking an appointment. I also did confirm it with multiple Walgreens and CVS's in town.
Thank you.
Yeah.
Perfect. Thank you.
So we are on the hour, so I want to let people jump off as needed. Maybe Dr. Doblecki, you could, if you're around for a couple minutes, you can answer some of those questions in the chat, and Dr. Kret's question as well. But for those that need to go to their afternoon obligations, thank you so much for joining. Please see the CME and MOC thing you have in the chat from Laura, and have a great week. And we'll see you again next week for Grand Rounds, which is also virtual next week before we move back to live on the 22nd. So please jump off if you need to. Dr. Kett, if you wanted to unmute and ask your question, if Dr. Doblecki, you're around for a couple minutes.
Yeah, I think I'm unmuted. So is Employee Health going to be offering the COVID vaccine? Because I called and they said they're not. And I'm just trying to figure out about that.
So my understanding is not. And if there may be other folks who are involved in that decision making who can jump in, but my understanding is that for now not. But of course, people can get it. They do have it, I will say, in the Walgreens and the towers, at least when I called them last week.
Okay, great. Thank you.
And then there was a question about the frequency of vaccinations. I guess two parts. Number one, is it updated every year based on the strains and the antigenic drift? And then secondly, based on those kind of declining vaccine effectiveness slides that you showed, does it suggest that we need to be doing vaccinations even more frequently than we are currently?
Great questions. Okay, so first of all, yes, the vaccine, the VRBPAC updates there kind of makes a recommendation around what they think the vaccine composition should look like. That happened this year, early in the year in the late spring. And then, but they've already been monitoring it. The manufacturers are already working on it. One of the nice things about the mRNA platform is that it can be where there's a rapid turnaround for being able to change the direction of vaccination. I think so. The question is, well, should we be getting it more frequently? So I think, last year, the CDC final clinical guidance was that for people over 65, and certainly for those with immunocompromised as well, getting a booster 2 to 6 months after the initial, booster, having a second update is useful. I think it does come back to what are you going to get out of it. I think for people who are in the highest risk conditions, that makes a lot of sense. For people who are not, I'm not sure that it does make a lot of sense. I think that the absolute benefit is still quite small. So I think there is some thinking about, what is the absolute risk and what is the benefit going to be from that. There also is, I don't want to get too much into the antibody thing, but there is some diminishing returns. This is why we have monovalent vaccines now instead of bivalent. Generally your immune system tends to tune to the first exposures that you had. For many of us, that was back in 2020. That's probably where our strongest response is. We want to now kind of try to target the variants. How hard do you want to hit it is another question. But I think that we don't really know the answer to that. I think it's pretty clear that for people in the highest risk groups, we should be thinking about vaccinating fairly frequently. And I would expect that there would be a similar recommendation from people when we get that clinical guidance from this year, that maybe after 6 months, a repeat vaccine would be appropriate for those people in the highest risk groups.
Thank you so much. I apologize that we're running a few minutes over. Thanks for those that stayed on. Any further questions, you can, of course, always contact our speakers. And Dr. Doblecki, you're absolutely right. This is exactly the reason we asked you to speak, because I knew that the CDC director would come out with something on Monday before the Wednesday grand round. So we timed it perfectly. If you're able to stay on and answer some of those chat questions, you're more than welcome to. But thank you, everyone, for joining. We'll see you next week. Dr. Von Herath, did you want to maybe, as everyone signs off, if you wanted to unmute and ask Dr. Doblecki your question? I guess you had a couple of questions.
Yeah, sure. We have been, thank you. We have been working on vaccination, of course, for a long time. And I used to be neighbors with Shane Crotty and these guys at La Jolla Institute. So a question that is always in my mind is, that the antibodies, not unexpectedly, are very short-lived in these coronavirus vaccines. I think that's fair to just say. And there's more question, how do we communicate this to patients, also those with severe risk, right? So, I mean, would you have to take a booster every month? And associated with this then is the mechanism of protection from severe disease. Shane Crotty and others used to work on these T-cell responses, but they also induced Tregs, timely because just Nobel Prize was given for these Treg molecules, right? And you could surmise, if I take a booster every month, at some point I'm going to become tolerant to the whole thing. And maybe that's good actually for severe disease, but that's actually probably not good for acquiring the infection. Then I'm going to have COVID every 5 seconds, right? So I just wanted to see in your mind what the latest research is on this. I haven't followed everything, but I remain very curious about this. So that's what was my question.
Yeah, I think those are great questions. I'm probably not the best person to answer it. I think those are really active areas of research, and looking at the interact, what are we, T-cell immunity is harder to study, right? So it's really easy.
Yeah.
It's really easy to monitor antibodies.
Of course.
I think that there's much less known about the other aspects of the immune system and how they're interacting with all of this. And we really don't know, I think, about about tolerance, or, you know, what's the counter, you know, what are the counter pressures here on the immune response, and how are we influencing them with the vaccines? I mean, I think we can see from the clinical studies that there is some brief, right, up to 6 months, decrease in clinical severe disease, right? So something is happening there that's in the direction of helpful. But what will that look like over time? I mean, everything we've talking about has evolved so much in the last 5 years. Who knows what we'll be saying 5 years from now? I think we have to acknowledge the unknowns here too.
Great. Thank you for staying over.
Yeah,
Have
sure.
a great week, everyone.
All right, thanks. Bye.